of the GEMA Humanitarian Task Force. What our goal is as part of GEMA is to get a place for, emergency medicine physicians within global health to really get together around work in humanitarian settings. And our kind of goal overarching is to provide resources in regards to research and helping you develop research careers, as well as kind of career goals more broadly. We have several projects going on. Our next meeting is on February 3rd. And I'm happy to send any information regarding our next meeting to anyone who's interested. We also have another webinar coming up on the 9th, which will be kind of more career oriented, and that's going to be with International Medical Corps. So I'm really looking forward to both of those things, and for hopefully more of you to kind of come and join our task force so we can work together on these issues. I want to introduce Kelly O'Laughlin. So Dr. O'Laughlin is an assistant professor in the Department of Emergency Medicine and Global Health at the University of Washington. She completed medical school at Oregon Health and Science University of Medicine, and she finished her emergency medicine residency at UCLA. So she's worked at Harvard previously, where she earned her MPH as well. Her research focuses on assessing the health needs of refugee populations and on designing and evaluating refugee-specific interventions to improve care, and has done significant work in Uganda, especially in the context of HIV. So we're really excited to have her here today. Thanks so much.
Thank you, Rebecca and Vinay, for organizing this. It's such a pleasure to be with you all today. And I gotta just say, looking at the list of participants, it's really awesome. I feel honored to see all the colleagues and trainees on the call. And I think it's just great to have this GEMA Humanitarian Task Force to bring us all together. So today I'm going to be talking to you about research in the humanitarian context, designing and evaluating health-related interventions in complex settings. First, we're going to go into unique aspects about displaced populations, and then quality of healthcare and related challenges, some considerations specific for research, and then some examples of my own research, which I'm working on to try to enhance the health of humanitarian crisis affected populations, and then some concluding messages. So again, just starting to look at hardships and unique aspects of life for displaced populations. And I just want to note right at the outset, I have a number of portraits in this talk, which were taken by my friend and colleague, Daniel Portal, and all with permission of the people being photographed to be included in talks such as this. But they are refugees in Uganda. So there are nearly 80 million forcibly displaced people worldwide, 26 million of whom are refugees. And a refugee, as many of you know, is a person who has fled war, violence, conflict, or persecution and has crossed an international border to find safety in another country. Refugees face hardships compared to non-displaced populations. They sometimes have difficulties accessing very basic survival needs, such as shelter, water, food. Many have suffered the impact of climate change. Dry land makes it difficult to grow food, as you can see in this picture, very dry, and to access materials to burn for cooking. And many have disrupted social networks, and they're often threats to their security. Some have even been exposed to sexual violence. Livelihood opportunities for people living in humanitarian contexts are often limited. Most people don't have traditional jobs. Many set up informal businesses just to make a small income, and some participate in transactional sex as a livelihood. And many refugees, different from how most people in the world think about it, many are displaced for a very long time. The average length of displacement is 17 years away from their country of origin. And refugee settlements can be quite large in some settings. That makes it complicated in terms of transportation. Transportation is often limited and expensive, and it's really not uncommon for people to walk 1 to 3 hours, even more, to get to where they're going. People who are very fortunate might have access to a bike or have enough funds to hire a motorcycle, but most people aren't that fortunate. And refugees are inherently mobile. Many continue to move even after their initial period of displacement for various reasons, including accessing basic needs, pursuing educational opportunities, seeking livelihood, visiting family and friends, attending events like weddings and funerals, and integrating within the local community. So that's just a part of life, this mobility. And there's a growing recognition that mobility, refugees' mobility, is a positive asset that can contribute to their lasting protection. And within that, the medical policy and research community has to collaborate and understand the implications of mobility on movement in the medical context so that we can enable refugees with medical conditions to engage in care in a way that's acceptable and that optimizes their health. And one last thing that I want to just plant in everyone's mind is the importance of community. In these settings, many people are relying on others to accomplish daily tasks of living by sharing resources and responsibilities. And social capital is essential and has to be used to rely on in hard times. And the community aspect of life has health delivery and uptake implications. So these are just kind of the threads and the backbone that I want to put out there as we move on to the next part of the talk. So first, just to introduce some concepts of quality of care in health settings and related challenges. Health systems vary from refugee settlements to internally displaced people camps, and they clearly vary across the globe. But there are some commonalities, such as resource constraints, unique challenges faced by populations that have been impacted by humanitarian crisis, like mental health challenges, sometimes sexually transmitted infection exposures, climate exposure, food insecurity. And there's also this challenge where sometimes the health care is embedded in the local health system and sometimes it's standing alone, especially during a time of acute crisis. And then there's the need to think about transitioning back towards the local health system. And healthcare provision during acute crisis can be particularly challenging given health system breakdown, disrupted supply chains, and focus on acute healthcare needs. In 2019, the Global Health Cluster Quality Improvement Task Team wrote a document titled Quality of Care in Humanitarian Settings. The goal of the humanitarian community in general is to ensure quality in the humanitarian health response. And there's a number of resources set up to try to help with that. First of all, the definition of quality of care, the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So in terms of humanitarian health response, some of these global standards are written about in the SPHERE handbook, the Interagency Field Manual for Reproductive Health and Emergencies. There's a number of guidelines that we could all kind of pull up. But I want to point out 7 domains of quality of care in humanitarian settings, as outlined by the Global Health Cluster Quality Improvement Task Force from 2020. And that is that care should be people-centered, safe, equitable, effective, timely, integrated, and efficient. And these are some of the domains that I come back to in my own research as I try to think of how to improve healthcare for people living in humanitarian contexts. And despite the intention of the goal of quality care, it's just really not always the reality. Here you see a picture of, a dispenser for condoms, and sure, it's a good idea to dispense condoms, and in this case, the dispenser is empty. So sometimes the burden of illness and the volume of people needing care can overwhelm health systems, and particularly during times of crisis. However, given most refugees are displaced for nearly 2 decades, chronic medical needs still have to be a priority. We still have to figure out how to do better. A couple more unique health challenges that I've come across in humanitarian settings. Health implementing partners often hold temporary contracts, and so they turn over frequently. There's often dense housing and lack of access to sanitation supplies, increasing the risk of communicable disease transmission. There can be many languages and low literacy, making it complicated to disseminate information. And treatment of chronic medical conditions can be less of a priority sometimes during acute emergencies. Barriers to quality care have huge impacts for refugees. Sickness can be harder to treat in these settings. Sometimes the distance to actual care or the cost of care is just insurmountable. And death is a severe hardship for people surviving, including widows and children. Some specific global health research considerations in humanitarian context settings. So one thing I'm sure many of you have come across is that there's many stakeholders and many necessary permissions before you dive into doing any work in a humanitarian setting. The focus of implementing partners is often on programs, and research might not be their priority. So sometimes that can be a tricky partnership to navigate. There's often lack of physical infrastructure to conduct the research. No actual site to do it. Sometimes you have to set up your own site. In this picture here, one of my early HIV testing research studies in Nacha Valley Refugee Settlement, we literally erected with permission a semi-permanent structure in this green tarp type tent so that we could do the work. Because as you could see, the structure that already existed on the left was already very full. It's certainly important to include the humanitarian crisis affected community in every part of the work, from planning to assessing the research findings and disseminating findings. This will help with understanding and disseminating and making sure that all of the work is important and relevant in the local context. And it's essential, as in anything, to have an excellent team. I feel like the success of most of my work has been because of the people that I've had on the ground and the fact that they are refugees themselves that come from different countries of origin and speak different languages and can connect with the participants. A few other additional considerations before I share with you some specific examples of what I've been working on. Evidence-based approaches are needed to understand the unique needs of humanitarian crisis affected populations. Some research questions conflict with what the Ministry of Health or the United Nations or health implementing partners actually want to know. For example, if you find a high HIV prevalence or adverse events related to an approved health program, or if you demonstrate poor quality of care, that can be tricky in terms of how to work with partners to make changes without causing problems. Some of the research is risky to participants or to staff, and that needs to be considered in advance and planned for. And then there can be issues in terms of identifying underlying problems, but not taking the next step, which is trying to help fix the problems. We don't need to just point out problems. We need to make changes. So in the next part of the talk, I want to share with you two quite different examples of bodies of research that I've led both in Uganda among humanitarian crisis affected populations. And I titled this section, Research to Enhance the Health of Humanitarian Crisis Affected Populations, because really that's my goal. I'm a researcher, but I'm not a researcher for the sake of publishing or getting grants. The reason I went into this was it was the way that I felt like I could try to make a difference in terms of public health related to this population. So the first study I'm going to tell you about is actually a series of studies, but all related to understanding barriers to HIV care engagement in Nacha Valley Refugee Settlement. And just for those who are interested or thinking about careers, I finished residency and probably didn't actually get my first funding to start working on this for like 5 or 6 years out of residency. And it took a series of mentorship meetings and kind of narrowing down my topic before I was able to dive in to get this specific. So the country of Uganda in Eastern Africa hosts approximately 1.4 million refugees. Nacha Valley Refugee Settlement, which is in southwestern Uganda, was established in 1960, is approximately 71 square miles in size, and the current population of refugees living there is about 130,000. The majority of refugees in Nacha Valley are from the DRC, Democratic Republic of Congo, Burundi, Somalia, and Rwanda. And the HIV prevalence from the refugees' countries of origin ranges from 0.5 to 6.1%. Routine HIV testing studies that our team conducted in Nache Valley refugee settlement demonstrated an HIV prevalence of 4.5%. And the surrounding prevalence in the region among Ugandan nationals was 7.3%. So our team studied the cascade of HIV care among refugees and Ugandan nationals in Nache Valley refugee settlement. And the motivation behind this body of research began when our team looked at the cascade of care. Basically, our team conducted a study, which was in 2013, to assess for those that we were prospectively testing for HIV. And in this study, we actually enrolled and tested 6,850 individuals in clinic-based routine testing. And we found 276 individuals to be living with HIV. So of the 276 individuals that we found to be living with HIV, only 54% linked to clinical care within 90 days of their diagnosis. And this really highlighted the need to investigate linkage to care as the next step in the care cascade. Because first you want everybody to know their status, then you want them to be engaged in care and taking art and be virally suppressed. But of course, and then the goal is to keep all of these up to 90%. But what we found at this time was very low proportion that actually, once they knew their diagnosis, would link to clinic, which was a big deal because antiretroviral therapy was free in that setting, but people still weren't accessing it. So our team conducted a follow-up qualitative study to understand barriers to care and approaches to overcome those barriers. And we enrolled participants after HIV testing and invited them to interview with us within 90 days of their diagnosis. We conducted semi-structured interviews with 54 clients, that people living with HIV, and 8 health workers, to assess participants' experiences accessing clinical care. And from these interviews, we had some important findings. We learned that refugees living with HIV face daily challenges that are barriers to engagement in HIV care, including food shortages, problems maintaining shelter, health needs, difficulty accessing potable water, limited childcare, difficulty with transportation, and limited emotional support. For some individuals, especially those able and willing to disclose their status to others, they were able to benefit from disclosure of their HIV status and social support, which would then allow them to overcome these daily challenges and successfully engage in HIV care. But for others, particularly those with anticipated stigma, post-traumatic stress disorder, depression, or anxiety, they often defaulted to non-disclosure and not disclosing their HIV status led to isolation. And with isolation, they were unable to benefit from social support to help them overcome the daily challenges and successfully engage in HIV care. Equipped with this information, we began a study to enroll a cohort of people newly diagnosed with HIV in Nache Valley refugee settlement to assess which factors correlate with failure to link to HIV clinical care. There were 3 enrolling sites in Nache Valley refugee settlement, all the same settlement, but 3 different health centers called Nache Valley Health Center, Juru Health Center, and Chibango Health Center. Adults accessing routine HIV testing at these sites were invited to participate. They included both refugees and Ugandan nationals living near and around the settlement or around that environment, accessing testing services. To conduct this evaluation, we surveyed participants prior to testing to evaluate demographic information, perceived health, testing history, distance to clinic, time in Nache Valley, and travel history. And we also used validated surveys to screen for depression, generalized anxiety disorder, post-traumatic stress disorder, social support, and stigma. We enrolled 5,568 individuals in this study, 65% of whom were refugees or asylum seekers, and 34% of whom were Ugandan nationals. Comparing HIV positive and negative participants, we had a total of 5,568 participants. We found 219 to be living with HIV, that was 3.9%. And those with HIV were more likely to be female, Ugandan national, and to screen positive for post-traumatic stress disorder. They were less likely to be living with a partner and to be in good health by self-report. This graph shows that the proportion of participants linked to care by years living in Nache Valley among those newly diagnosed with HIV. So on the x-axis, you see years in living in the settlement, and on the y, the proportion linked to care. I always thought that was possibly interesting because I kind of hypothesized that maybe people that were newer arrivals were less likely, or maybe people that had been around long enough were less likely for some reason, but we found no statistically significant difference among these categories of time and linkage to care. However, this may have been related to small sample size and the reality that some participants didn't answer this question. This study showed, though, that health status, health limitations, prior testing, and distance to clinic, surprisingly, none of those were associated with linkage to care. In evaluating the cohort of individuals newly diagnosed with HIV and looking for associations with each of the following rows, post-traumatic stress disorder, depression, anxiety, social support, and stigma, with linking to HIV clinical care, the only significant finding was social support. The presence of social support was associated with linking to HIV care. The summary of these findings is that social support is associated with linkage to HIV care among those testing for HIV in a refugee settlement. Interventions should be designed, implemented, and evaluated to foster social support for those living with HIV in refugee settlements to enhance HIV care engagement. And stay tuned for a follow-up on this one. I'm hoping to get NIH funding to do a multi-site randomized cluster trial that will look at community-based art delivery as one form of social support at the time of diagnosis to try to enhance viral suppression for people newly diagnosed with HIV in these settings. The second study I want to give you just as an example of what I've been working on is totally different, but is also in Uganda and is also related to refugees. And it's called Dial COVID, Remote Mitigation Through Telephone Symptom Surveillance in Refugee Settlements in Uganda. And this was funded by ELRA and was done in partnership with colleagues in Makerere University at Infectious Disease Institute, at Harvard Humanitarian Initiative, with Medical Teams International, and with Viamo, which is a telecom company that was started by Louis Dorval and Lara Vogel, for those of you who know our Harvard colleagues. So background, limited screening of refugees for COVID-19 symptoms and exposure, and there's a paucity of data on knowledge and risk perceptions, ability to adhere to preventative measures, and barriers and facilitators to prevention and control measure adoption for refugees. Telephone-based interactive voice response technology, in which participants respond to recorded audio questions by entering numbers on the keypad, could be an effective way to collect info and share info in a humanitarian setting. Interactive voice response, which is also known as IVR, is quite simple, and it's something that we actually have used many times in our lives, but just don't know the name of it probably. It's basically when you place a phone call into a system using any phone, any simple phone, doesn't have to be a smartphone. Listen to a pre-recorded message, it gives you prompts, and you answer 1, 2, 3, whatever corresponds with your correct answer, and then you can listen to a pre-recorded response, which can be based on your answer. So that's IVR, interactive voice response. So the Dial COVID study design, it's a free telephone hotline designed for use in Uganda, created in 10 languages, using IVR to collect and disseminate information. This had two branches, this study. There was a dial-in component where participants would call into the platform. They would receive the symptom survey about COVID-19 symptoms and exposures, and then they would be given information, tailored public health information. A comparison random digit dialing sample was also obtained using just Ugandan phone numbers randomly generated to try to understand how did our cohort recruited from refugee settlements differ from a Ugandan kind of cohort from the countrywide. A subset of the call-in participants, those recruited in refugee settlements across Uganda, were also invited to participate in COVID-19 testing to try to validate a predictive algorithm using the dial COVID info, in longitudinal survey to assess COVID-19 knowledge, risk perceptions, mitigation strategies, and vaccination willingness and hesitancy. And finally, qualitative interviews to understand barriers and facilitators to the adoption of COVID-19 measures. So I want to give you a brief summary of what we found because we're just concluded this study. So basically from March of 2021 to March of 2022, Dial COVID was advertised by Medical Teams International Village Health Teams in 24 of 31 refugee settlements in Uganda. Those 24 settlements are home to more than 880,000 refugees living in Uganda, which is about 56%. And here's a map of where we were. And here is a picture, a poster, an example, though it was available in many languages, of what was used to disseminate the information about the study in the settlements. Basically teaching people, you call a line, you hang up so that it calls you back toll-free. Then you interact with the platform by listening, pushing the keypads, and getting information at the end. So over this study period, we had, for call-ins, 5,436 calls into the platform and 10,400 public health messages shared. Through random digit dialing, we reached 9,192 individuals, with 3,700 staying on the line to receive public health messaging. Of the subset that we tested for COVID, there were 741. These were 34% female, a mean age of 28, 31% had never gone to school, 50% had some primary school, only 17% completed secondary, and 1.5 had more than secondary school. Nearly all lived in the refugee settlement, which makes sense because that's where we recruited them from. And the time that they had spent living in the refugee settlement, for 86% was more than 5 years. And not surprisingly, the mean household size was 5.5 for these folks. So of those that we tested, we found 48 to be positive with COVID. We compared controlling for demographic characteristics among the symptoms assessed in Dial COVID. We found that strong muscle pain and unusual fatigue were the two symptoms associated with COVID-19. Heterogeneity of symptoms between COVID-19 variants challenged the development of a predictive algorithm based on the symptom survey, not surprisingly. We did find that the comorbidities associated with COVID-19 were hypertension and diabetes among our cohort. The second component of this study, which was a longitudinal survey, there were 3 rounds that were conducted in late 2021 and included a dial-in cohort of the refugees and a comparison cohort sampled through random digit dialing. Participants were asked about risk mitigation behaviors, including washing hands, wearing a face mask, staying 2 meters away from others, and staying home when feeling ill. And the majority of dial-in and random digit dial participants responded that they did follow these recommendations, though the proportions, as you can see, decreased over time with these downsloping lines. There was lack of money for supplies and circumstances required to carry out essential tasks. Those were the 2 reasons, most prominent barriers to mask wearing and social distancing, respectively. And only about 60% of surveyed call-in participants and about 75% of random digit dial participants said that they would accept a free COVID vaccine if available. And the main barriers that they cited to vaccination were concerns about safety and side effects, uncertainty about efficacy, and stigma from the community. Finally, we did 26 qualitative interviews and just some big key findings. One about barriers and facilitators to prevention and control measure adoption and protective behavior in specific. Participants expressed a desire to protect themselves and their families from contracting COVID-19 and reported adopting prevention strategies like face mask wearing, social distancing, and hand hygiene. COVID-19 risk perception and adoption of risk mitigation strategies decreased over time. Regarding COVID-19 vaccination, participants were generally favorable, but knowledge gaps and myths surrounding the vaccination persisted among a minority of refugees. Factors unique to the refugee settlement context included resource scarcity, high housing density, and necessity to leave home to attend to survival needs. And these influenced the extent to which recommended prevention strategies such as isolating, quarantining, and avoiding crowded places could be adopted. And there were some negative impacts that are worth noting. The pandemic and related policies negatively impacted income generation, food security, and social interactions in the refugee settlement. And school closures were thought to have contributed to incidents of child marriage, as well as teenage pregnancy among refugee youth. So the lessons learned from this Dial COVID project was importantly that an interactive voice response platform could be used to rapidly collect and disseminate information in many languages in difficult to reach places. The Dial COVID tool could be adapted for other applications like routine surveillance or future outbreaks of other transmissible diseases. We felt that future research should focus on optimizing IVR implementation by identifying strategies to facilitate uptake and to understand differences in uptake across refugee settlements, because we certainly found that some refugee settlements, this was a tool that was used widely, and others, it didn't work as well. Digital literacy and phone access should be assessed as well to identify population subgroups that may not reach by this intervention. Because while we felt like this was a step forward because it did not require a smartphone, there were still people without access to basic phones, or who still had a hard time interacting with the IVR platform. So that's the second study that I want to share with you. I'm just going to give you two conclusions and take-home messages, and then open it up for some discussion. The first of which I think all of you will agree, which is that humans deserve to have accessible, acceptable, quality healthcare in humanitarian settings. And I will tell you, research in humanitarian settings to inform tailored interventions for this unique population in this unique setting is absolutely needed, and is needed in about every category in every sector you can think of. So there's space for all of us and 10 times more to do way more work. It's very challenging, but really rewarding. And I hope that all of you join me in these efforts. So I'm going to open it up to you guys now so we can have some discussion and conversation. If you have a minute to scan that QR code and submit feedback for me, I would love it. In fact, my institution requires me to collect it, so it actually would really help. So I welcome you to do that. But I invite some comments and questions. I did note that Sonia wrote in the comments, she can imagine social support is a factor even in New York City. I absolutely agree. And, you know, I love in this work thinking about lessons we can learn from the African context and apply, like in Seattle, there's probably a lot of benefits if we could integrate more social support and community health workers and all that. So I totally agree with you.
Hi, Dr. O'Laughlin. This is Charlotte Roy. I have come across your research quite a bit because I've done some research on GBV in Uganda, among other countries. So it's nice to hear you talk. But I was wondering if you could speak a little bit more about how you got involved in this specific settlement and kind of how you got your start doing research in this area.
Yeah, thanks, Charlotte. That's cool that you've come across some of our research. Great question. I did my master's in public health at Harvard immediately after residency. There, I became very interested in displaced populations and refugees, and it was kind of more of an academic interest from everything I learned from coursework, and it really wasn't from lived experience or rotations or anything, though I'd had other global health experiences. But I was in Boston around a lot of people working in humanitarian health, and specifically the Harvard Humanitarian Initiative. And I basically just I became interested in wanting to help through a research lens. And so what I did was I tried to find mentors or anyone who could help me learn about research. And I knew that I just wanted any research knowledge. And they didn't need to necessarily be in a refugee settlement or have that context. So basically I partnered with David Bangsberg, who was at the time the director of the Harvard Center for Global Health. And his expertise was in HIV adherence monitoring. And he had been in Uganda for decades doing work. And he knew that Uganda was one of the main countries in the world hosting refugees. So he said, why don't you look at HIV adherence among refugees? And that's actually where I kind of thought I would start, until I realized it was kind of silly to focus just on adherence when I didn't even know what was needed. So I ended up taking a step back and starting with qualitative research there. But I actually just went to Uganda and met people to try to find out what the needs were and where the population, because I wasn't sure when I first went whether it would be refugees or internally displaced people. So I was just trying to think of what would be feasible. So I had mentors guiding me in the science aspect, but not really in the location or the population, which isn't ideal, but that was just kind of the lay of the land at that time.
And so you just sort of showed up and found out about this settlement. And then my other question, I feel like the big question for everyone is always funding. Like, how did you have funding at first, or how did you figure out how to get funding?
Great question. So yes, I showed up. I brought a friend so that I wasn't traveling alone, a physician assistant that I was working with, Hannah Dubsky. And I showed up, but I showed up with introductions to like deans at the med school and like a bunch of academic contacts. And then in country, I followed up with everyone they recommended that I follow up with in the context of what I was interested in. And just by chance and circumstance or something more divine, I was introduced through a PhD in horticulture. I was introduced to my project manager, who I've worked with for like 12 years now, because she had just met him on a bus, and he is a refugee from the Democratic Republic of Congo, but he had moved to Uganda and gotten his master's in development studies. And he became my long-term kind of in-country partner or refugee cultural liaison. But after that, and after kind of meeting with people from the Ministry of Health and the UN and trying to understand what they were interested in and what they thought the needs were, I applied to a series of grants, and they were all kind of small institutional grants. You'll find that when you're like early faculty, there's options for like $10,000 here, $5,000 there, $20,000 there, which seems, I don't know if that seems big or small. It's not very big, but when you're just starting in Africa, you don't need that much funding. The one that got funded first, thankfully, was a qualitative study. And I think it's because you can't really get bigger grants without pilot data, or without even showing what the needs are, or without showing that you can be on the ground and do the work. So it was a series of small Harvard institutional grants that helped me to get the pilot data that I needed to do bigger grants.
That's amazing. Thank you for sharing.
Absolutely. Vinay, how did you logistically carve out time to do this early in your career? Great question. So when you first finish residency, you feel like you have all the time in the world because you have so many shifts as a resident that you're like just trying to learn and breathe and eat and maybe exercise if you're lucky. But when you finish residency, depending on what else you have going on in your life, maybe you have like 12 8-hour shifts a month, or 12 to 14 or 16, depending on where you are. So immediately you have 1 or 2 days a week where you're like, wow, I can be productive in an academic context. And if you're at an academic site, you're expected to be. So you're expected to use that free time to figure out what to do in your career. So for my first bit, it was that. And then shortly after that, I was involved in a number of projects that would come with some buy down. I was telling Rebecca before this, I worked on a Department of State funded grant or like a series of grants for like 5 years called Peace Through Health, that brought together Israeli and Palestinian healthcare providers around healthcare topics to try to kind of build relationships across lines of conflict. And the last iteration of that grant also included Native Americans. That was amazing and gave me some more time to do global health work. It wasn't research yet, and it wasn't mine because I wasn't the PI. I was like I was basically the project manager, even though I was probably listed as co-PI. So that when you sign up for some things like that, all of a sudden, the way that it works in academics for every department is a portion of money from that grant pays for you, and that takes away another shift in the emergency department. And what you're negotiating for when you sign on as faculty is, or what you want to ask when you look at all the different places is how much is one shift? Is it 10% effort? Is it like what exactly on a grant will equal what amount of time in the ED? Don't get me wrong, I love clinical emergency medicine and I'm so glad I have both, but you eventually need less shifts to be productive in this research space. So eventually that comes from either program or grant funding, depending on what you're up to. Super good questions. And then I also will say, I will brag that at Harvard, I was so lucky. I always, whenever someone said, you should meet with so-and-so, you should meet with so-and-so, I always did. Even if I was busy and I was just like, I have no idea how I'm going to find time. But one of the people I met with, and I really didn't go with an ask, was Rochelle Walensky. She's now the director of the CDC, but at the time she was one of the co-directors of the Medical Practice Evaluation Center at Mass General Hospital. And I met with her and told her about the qualitative study that I had done in Nacho Valley, where I learned about people living with HIV in that setting and their needs. And she was really moved because she had never thought about refugees before. And basically after that meeting, she invited me to come sit with her research group and work with her and learn from her. And it was in that setting that I learned how to write a K-23, get NIH funding, and do work that was kind of much more detailed in terms of NIH level. And part of what she did for me was negotiate with my chair so that I would only work 8 shifts a month while she was mentoring me to get my K. So in that sense, and then they made some deals as far as transferring of funds, sundry funds, I'm not sure. But basically I got to work 8 shifts a month for about 2 or 3 years while I was 6 or 7 years out of residency, switching into NIH funding research. Laura asked, what am I working on now? I alluded to it a little bit, but I have an R01 that's being considered through the National Institute of Mental Health. And I'm hopeful, I have a score that looks good and I hope it will get funded soon. But it is a cluster randomized trial that will be in 12 health centers in Uganda across the country. And basically 6 of the centers will be standard care, 6 centers will be the intervention. And as it is now, if you're newly diagnosed with HIV, you receive facility-based care. You go to the facility to get your antiretroviral therapy. But what we've learned through the research so far is it's far, there's stigma to go to clinic. a lot of people don't disclose. So one of the differentiated care models already in place for people who are stable in care, meaning they're virally suppressed already and showing that they can do a good job going to clinic, is community-based ART pickup. So there's community-based ART pickup at a designated spot, and there's also community-based ART groups where you meet as a group and take turns going to clinic. So my study basically will put those interventions earlier at the time of diagnosis instead of making them be stable in care in refugee settlements, to see if that works for helping with viral suppression and linkage to care and engagement in care. And from what we've studied in refugee settlements, I don't see how it wouldn't work. So hopefully that will be funded. I also have a bunch of domestic COVID work, which is new for me, and who doesn't? But I'm involved in looking at increasing uptake of the COVID vaccine among vulnerable emergency department patients, overcoming vaccine hesitancy, and also a study looking at long COVID. And those are other examples of ways that I fund my time so that I can do pretty much the work that I've been telling you about. But sometimes it helps to just put 10% here, 20% there on a project that you're not entirely leading on your own, so that you can also have more time to do whatever you want to do. Vinay says, having been a mentee and a mentor, what are the elements of a good mentorship relationship? Whew, that's a good one. I think commitment from both people is commitment is important, because if you're a mentee, you need your mentor to write you back right away. You need them to know you, help you decide when to say yes and when to say no. But all of that is just a commitment to like knowing you and guiding you. There's certainly a compatibility for, somehow you jive or you don't jive, and that just might be meeting with them to see if you're inspired by them and they're motivated by you. So there's some type of unwritten rule, but that you both like each other and it's compatible. And then I think be organized, because we're all so busy and there's so much on everybody's plate. So every time you just be respectful and organized. So if you're going to show up to a meeting, know what you want to get out of it and be on time, and give them a agenda, and just be efficient so that you can both benefit from it as much as you can. You guys should all turn your cameras on for a second so you can see each other if you're not in your pajamas. There's Laura. Hi. Yeah, these are all our colleagues. This is our future right here, everybody. Hi. Renee's working. Nice to see you. Hey, Sam. Look like you. Good to see you. Yeah. I'm thankful again to Vinay and Rebecca and the other folks leading the Humanitarian Task Force, because I think it's really nice that we're able to come together in this setting. And I know that we have some big events coming up too. Vinay, you want to tell everybody, or Rebecca, do you guys have it on your mind? February 9th?
Yeah, so we have one on Friday, which is at 11 o'clock Eastern time, 8 a.m. Pacific time. It's a webinar with International Medical Corps. It should be really good. I'm really excited. They've been very invested in making a great informative experience for y'all. So if you don't have the information, please just give me an email and I can get that to you. We'd also love for anyone who's not involved with the Humanitarian Task Force or GMA generally. There's a lot of great opportunity to get involved. I got involved a couple of years ago. That's how I've met all these awesome people. And it's been it's been really great for just, finding a group of people who are interested in the same things that you're interested in. So we really depend on the folks who are interested in this work to kind of actually sustain it. So just shoot me an email, because I will not have access to these messages after the chat closes down in a few minutes and I'm at work. So just email me.
Awesome. And I saw one more question. Christina, thank you. You said, can you talk about IRB processes as it relates to international setup? So generally, hopefully you're going to start small in one site. I always had an IRB at my own institution and then one in Uganda, and it has changed, the one that I've used. It's weird because most of the stuff in refugee settlements or off the grid, not in a city, is not affiliated with the university. But any of the universities will be happy to take your money and your application and review your research and eventually approve it after asking a million questions and making you go back and forth if you did a good job. But the best scenario is that you have a local partner who is affiliated with an institution, and then that's best. But I will say for my first like 5, 6, 8 years, my local partners were the UN and Medical Teams International, and no one had a university. But I just would go to the Makerere University and they knew that I was just this researcher who was partnered with NGO people outside of academics, and they're happy to review your application. If anyone ever has any like specific questions like that or anything else, feel free to reach out. I'll put my email one more time there, but happy to share any info. Yeah, I see that the SAM account has posted the link to the next talk called Humanitarianism and International Medical Corps, a view from EN physicians. And thanks everybody for your comments.
Thank you so much, Kelly. This was amazing. You are an inspiration to all of us. And really thank you for starting the series out. Awesome.
Yes, thank you so much. And remember, if really feel free to email either me or Vinay if you would like to get more involved. And it doesn't cost you more to join GMA, to join any of these task force if you're already in SAM. So you can, connect with us to get all the information.
Awesome. Thanks, you guys. Thanks everybody for attending.
Thanks, Kelly.
See you soon. Bye.